Hello and a warm welcome to my webinar, Digital Workflow for Happy Patients, Reliable and Predictable. My name is Dr. Stephan Sinhuber. I'm coming from Germany. In the north, there is a city called Hamburg. I was born there and I studied there in the military to become a dentist. After that, I went to Berlin for 9 years to work there in the Central Military Hospital, and I made a master degree in aesthetic and reconstructive dentistry. Nowadays, in 2005, I started my own private practice in Ganderkesee, a small town near Bremen, and I'm working together with a partner in my office. Bremen is a very old town. 800 after Christ it was founded, and the most important thing about it is that it was a partner in Hanseatic League in 1200 to 1700, and it grew very much in merchants with economics, politically and culturally. Nowadays, digital tools are spreading everywhere. As we see here, a robot in Incheon Airport, International Airport from Seoul, Korea, it should help travelers to get to their way easier through the airport. Using digital healthcare or remote control in your house, virtual tours through the neighborhood, everything is more and more digital. And we don't know what is the main purpose of this, but everyone uses them, and not only the young guys are going to handle this in the new times. And nowadays it is very interesting to see what kind of preferences or benefits this brings to me and my patients, and how these things can help us in our daily practice with our work and with everything. So be clear to see what you need and find what you want. But to start with my lecture, my story in any rich and one-day implant is a life-changing thing for me, because it makes my work, my daily work, much easier. So I want to show you a simple case. This is my patient. She's Petra, and she has a problem and wants something that she can rely on, and it has to be predictable for her. Her problem: 2 missing teeth, number 35 and number 37, and as she said, no problems at all with her teeth, but these were missing, and she wants me to put a new implant in. I said, okay, let's have a look. We had a look on the upper. We saw some crowns, we saw some filling, seemed to be okay. We saw the upper and the lower, and of course we saw the occlusion and the bite. And what we saw is that we have a deep bite. A deep bite, Angel class 2.2, and inclination of the anterior upper tooth, and very, very strong contact in the anterior. Even though this is not so important to the patient, it is very important to us. And the next step will be a panoramic overview by the panoramic X-ray. And when we saw the X-rays, we saw some little problems in the lower. As you can see here, it's 2 infected teeth on the panoramic. We saw that there were 2 missing teeth, and we also checked the approximate bite, and we saw some decay in the upper, but quite well information of the bone in the lower. We also saw that there is an extrusion of the upper 2.7. So what we did first, we have a very good endodontist in our team. So he removed the old root canal fillings and did new ones, so we had no problems with the infection. We also did some fillings to the caries we saw, and then we went on to go for the cone beam CT. We have the cone beam CT in our office, so it's easy and simple to do it for us, and especially when we need the 3 dimensions of the bone, we will go for the cone beam CT always. And we find that it helps us a lot to see the bone in different angles and see how we can manage with this deal when we have to deal with implants or with any infection in the bone. Because when you know where it is, it's easier to solve it and easier to get it. And we can also see that the bone in the 37 is very hidden, and it helps us a lot. The next new thing we are very proud of, we are happy users of the R2 iris in our office, and this makes it possible to have an intraoral scan with us. So as you can see here, in slightly forward mode, it's a very quick way of scanning the whole upper jaw and lower, of course, and even with metal things, you can see that the metal is quite well catched by the scanner. So it's very fast, we think, and it gets us one jaw within 2 minutes, so we can handle it. And it's okay to get in touch with missing things, as you see here. It sometimes has to be redone by another angle, and then we can start to go on with this as we did before. So it's a very nice thing to have, and helps us in this case very much, because we have the opportunity to see what is the missing parts, and then we rescan the missing parts, like the metal upper metal crowns that are vestibulally on porcelain, and a lingual side, palatal side on metal. As you can see in the, we can close the gap to the scanner to show that this missing parts are easily to be intraorally caught to the model. So what we get then is we get a virtual model that we can see the problems of this case, and most of the problem what I saw in this case was 2 erupted tooth 25 and 27, and an occlusion that seems to be very, very narrow in this case. The 22nd tooth, number 22nd, is very small, and we had to check what filled this up more. So we had to check the occlusion. The occlusion in my hands is one of the key points that we have to check when we have a case like this with single teeth that should be removed or should be restored. And when we do that, we always use a double colored paper for occlusion, and see where the contact points are in the patient. And to make this in the virtual model, we have to check the occlusion as well. And on the scanner, we can do that quite easily. We have a special program to check the bite, to redo the bite, and what I like a lot is that we can see the measurements from nearly 2 millimeters to 0 millimeters, and even less. As you see here, there's black spots on the 36, so it seems to be a very high contact on that, and that comes very similar to the movie that we saw into the picture with the occlusion. And also we often find that the occlusion might be different in the scanned areas to the model or to the natural areas. So this could be a pitfall. A pitfall when you forget about the occlusion. And the most incredible thing is you should not even forget about the occlusion, but you should also think about the function. And when you think about the function, you have to be aware of typical aspects. And the aspects for the function might be that there is someone sleeping and doing the grinding. The grinding is for me a very important thing because we have to protect the function of the bite. And how can we protect the function of the bite? We have to be aware of the position to prevent this. We have to prevent the people from bruxing, and they sleep and they don't check it. And sometimes their partner tells them, "Oh, you're bruxing the whole night, you're scratching, you're clenching your teeth." But grinding and clenching is the most difficult thing for us in this case, or in most of my cases, because when I see my patients, I see more than 2/3 are doing something with their teeth in the night, something like clenching and grinding, even though they don't know. And for me, this is very important to tell the people before and to check this very much in the beginning when you go for it. So next step in the procedure of my workflow is I always get the information from the German or from the R2Gate Center to my iPad. I love to work on the iPad because the iPad shows me a lot of things. I can change little things and I can check this. And I have my iPad with me every day, so it's easy because when I see that there is something to be done, I have to check this, and I can have a 2-minute break within my patients and check the R2Gate to light to see the new changes of a new patient's case. And with this, it helps me, especially with the new update, with the new abutments, that we can have different abutments on top of the implants, that we can have in different sizes. I like the Surgeon abutment very much. As you can see here, it has the cuff heights. You can change that. You can see when you change it what happens to the bone. This can contact the bone. You can change the post height, so you can have a longer post height, but this will contact the upper tooth. So in this case, I will just change that. And we also can see the angulation of our abutment, or we can change the different cuff heights and see which height would be working fine. Because when I like to have an individual abutment with me, and most of my patients prefer a ceramic one. So this is why I work with the Surgeon abutments a lot. But I have to find out a way and check that. And with a new update now, I can do that easily. And it's very, very helpful for me that the software is now having all the abutments. You can change the abutments, you can change the angulation. And you see, well, this time in here, this Surgeon abutment should cut contact to the gingiva, that's yellow in this case, and should have a good space in the lower and the upper. So sometimes I even can see when it's horizontal very near to the contact of the proximal or the upper tooth, then I can see how this will work with me next time. So I can drop the implant a little more down. Even with the 37, I can check also the digital eye, so I see the different conditions of the bone. This is an aspect that I like very much, not only for the drilling but only for the angulation. In this case, I used an angulated abutment to get near my axis of the implant that is more in angulated way. So I used a 17-degree abutment will help me with this case. And also what I like a lot is to contact my patient and tell the patient with the iPad how I could solve the problem, and then we can give this to the company again and tell them, okay, now we can go on working. So I told you I like the Surgeon abutment, but one thing I don't like at all is when I have a standardized abutment at all. Because standardized abutments will always have the cementum junction very deep in the gingiva, and on periodontal reasons I don't like that. So I prefer the customized abutments, but I also prefer the individualized abutments with zirconia whenever it's possible. In this case, the technician now showed me that he had some problems because I told them to take the 3 millimeters cuff height of the Surgeon abutment. He sees that this will be a different difficulty to have either the gingival size of the abutment to the gingiva. So he was thinking that we had contact of the metal parts out of the bone, out of the tissue, and also he's told me that there is not too much space for him. So we decided to change my case one more, because we changed from the Surgeon abutment to an individualized abutment in metal or in titanium. So it's a milled abutment that I will get in titanium. I was supposed to have this only on the 37, but now we decided to have this on both of the teeth, of the tooth. And also we can check about the provisionalizing, because when we have the one-day implant, we will always get the information for the abutment and the provisional things, and we can talk about the occlusion. And as you can see here, it is very deep contact, and I had to tell them that I want to have the provisional a little smaller, and also I like that the lingual and the buccal side is served like on the neighborhood teeth, so they can check the length of the provisional to the area of the cementum. And the cervical reason, I like it more like you can see it here on the buccal, when it's one side to the other, and if you have a line in between the natural teeth, I want to have the abutment the same way. So make sure that the cementum will not go into the gingiva later. Of course, everybody probably knows that we will have a diagnosis report when we send this to the R2Gate Center, and we are impossible to see now our abutments, and we also be able to see a drilling protocol. The drilling protocol I like a lot, and if you are working with it, you will know that it's very, very good to have an idea for you and your assistants to see all these drilling steps. And for me, I start working with the Excel sheet once better than the PDF file. If you have a computer in your working room where you do your surgeries, you sometimes can change things out of the Excel sheet that you can't do with a PDF file. And the changing of the bone density, for example, or changing of the diameter of the implant will change constantly the R2Gate drilling protocol. So what you can do now is within the surgery, you can tell your assistants, please switch the bottom for the bone density, and then you will have the new drilling protocol. And this will help you a lot in surgery to be a little more flexible and to show this to your patient, to that the workflow is going more easy. So we also know on the worksheet, on the report, there is the drilling depth. There is the most important thing, how to work with the carrier. The carrier of the implant will have different windows. Nowadays, we will always also have the windows on the lingual side. So for me, in this case, it was easy because we could just check the window of from both sides. So when I get my things in front of the surgery, before we start the surgery, I would get my models, I would get my provisional crowns for both teeth, and I got the pre-milled titanium individual abutments. You can see very, very clear that we have the cementum junction very high in the same height as we like it in both sides of the bone. And also in this case, very special, I use a splint for biting to check and prevent my implants. I always prefer that when I see these bites, because when you see it, you will have a much better idea how to do it. So now I go on with the surgery. And the surgery, as you can see here, shows a very good fitting of the surgical guide. We see no gaps. We can go for the incision very, very fast. I like to do incision by doing this. I don't need punches because I don't want to lose any attached gingiva around my implants. I want to save it. And this is why I always use the scalpel if ever doing these implant surgeries. And as you can see, we find the bone exactly in the way that we saw it on the cone beam CT before. It's a very wide bone this time. We are lucky, and we could drop and put our drilling of the bone like it is written on the drilling protocol. And it is very, very good to feel the bone density by drilling the bone. And you have to be aware that there might be changes in our surgery, so you can change that. Sorry for the implant videotaping. It is not very difficult. It was very difficult to get that on the backwards on the 37. As you can see, I always use the hand ranges, and sometimes you even have to redo or just move the implant a little back, because when you miss the window and you're stuck with the bone, you just prefer to go on the windows. Here you can see the both windows on the surgical guide. Then we put on the ISQ. We always do that because we want to do and want to know whether it is possible to load it. Then we have the titanium abutments on 37. We have to hand screw it, as we are seeing here with the hand ratchet to 25 Newton centimeters. And now it comes to the abutment 35. And you can see I had some problems. So what happened? The bone had contact to the abutment. So I used the bone profiler kit. And as you can see, there is a guide pin that you can put in the implant, drive it in with a hand driver, and then use the bone profilers to open the bone a little more, so you can have it easily to put your abutment in. And with this thing, I can do this case very easily, even though it was not planned. Sometimes you have individual marks on the abutments that can help or can give you problems with this. So when we are finished with the bone profiler, we have to reduce it. These things get stuck by the bone profiler sometimes, so you have to use some more force to take them out. And then you can see the individual abutment is coming very easy into the area I wanted. And good to be seen that you can drive it with the hand driver and the hand ratchet to 25 Newton centimeters. Then you can close the flap, easily closing, and happy to have all the abutment, all the connected tissue. Now you see the provisional crown coming in, checking the vitis very first thing, and you see how the how the crown has contact. I had to reduce that contact because I don't like to have my contact very strong. So I removed that. I checked the flossing because I want to know, is the contact point good for cleaning, because my patients should clean their implants right from the first week. And it is very necessary that they can do that. If they can't do the flossing, they won't clean it. So this might be a problem. But here the provisionals are in and I'm happy. We check the bite once more. And there you see I have nearly no contact on the 37, a good contact on 36, and up to no contact on 35. So this is how I do it, because then I know it might be predictable. And also for the sleeping, the patient gets a biting splint. So once more, for those of you who don't know the profiler kit from AnyReach bone profiler, it has 4 parts of the drilling, the profilers. It is 4 to 7 millimeters, as big as you know it, as you need it. I always start with number 4 and go to 5, depending on the depth, and the abutment must sometimes go to 6 diameter. There's always 4 guided pins within the set, and I am very happy to use this very often. So after the surgery, we have to go for the panoramic, and we see that the implants are placed, well placed in this case. When you check the individual abutment, you see that there is a good space. And if you are very clever, you can see that in this area it is a little less on the distal side, but still the conclusion is you got the implant and the abutment straight together. You can check this by the little dark dot here in the middle of the implant. If this is the same side as you probably had this on the other, then it's easy to know. And we have got a good insertion torque. By the hand ratchet, we can measure it very clearly. We have 68 Newton centimeters on the 35, 65 Newton centimeters on the 37. And even though I turned around the 37 a little back, as I showed you in the video, then you can see the ISQ is even better. That doesn't come from the ISQ, but it helps us to have the insurance for the patients that we have a reliable implant and we have a stable position of the implant, and we can load this if we want, but we don't want. Still, I checked this case after a week when I took out the sutures. Some of you might see that the swelling is still around 35, sorry, and but most of the healing is starting very good. And also we checked the bite and we saw that there's not too much pressure on the new one-day implants. And also 2 weeks after surgery, we see the healing and we see the climbing of the gingiva in between the bone and the provisional, and for this the patient is very happy. So in this case, if you are aware of the problems before the surgery, and this is what I like about the digital way very much, then you can solve problems in before. And especially on the conclusion of the occlusion, it is easy when you have the possibility to check this. And if you see the biting impressions of the start on the left to the right, then you see after 3 weeks there is already gone very much in motion on this functional splint. But another thing that I like a lot about the digital dentistry, I can think it more globally. Because when you go with data, you can either go within Germany from the Artugate Center to the dental technician to back to Bremen, what is quite a distance, even though Germany is very small compared to the world. It is up to 1,516 kilometers or 942 miles for those of you who are on the other side of the world. And this is quite a distance for any of our parcel systems. If you send this by normal mail, then it's much, much faster. So within short time, I can go somewhere else with my data, and we can discuss this as you saw, and we can just find a way how this could work out for the patient. And of course, another way is to go around the world. Because when you go to Japan, for instance, you see that there's a much longer distance, like it is 6,223 miles now, even though we had to go back to the dental technician and get back to Bremen. But the most important thing with me in this thing is that there is a time change. Whenever I go to sleep late at night or whenever I stand up in the morning, there's someone who's already working. And sometimes this helps me to count the hours in between when my case has to be very, very quick, like when there's an accident. Not this time, of course, but when there is a drilling of, there is a problem of time, then it's easy to have a contact on the other side of the world. And I tell you, you should think about this very, very closely when you work with the Artugate Center. So in my chance, I had the chance to meet John Kim in Japan, because he's the leader of Megagen Japan, and he was helping me to get in contact with the Artugate Center Japan. So I was happy to be invited, and I was happy to talk to the technicians from Johnny's factory in Japan, and they helped me a lot with my cases. And it's good to know that they know a face and they know who is the doctor behind the scene, even though they only get the data, and they can do the Artugate software and they can match all the problems. It's better to know each other very, very well. So the thing, this helps me a lot for my patient is to have a happy patient. And the happy patient is the thing that I love to have in my office, because these people tell other people to come and they see, okay, this works with him, this works with me. And the thing is, when the patient is happy, we are happy, and we want to see that we can manage. And a funny smile off his face, we can have a lot of fun. Reality check.
Tell me where is the gate?
The problem is.
Can you tell me the way to the gate?
안녕하세요. 저는 에어스타예요. 저의 도움이 필요하시면 화면을 탐지하거나
This air had listening problem because my English is so bad. And as we can understand, there is a learning curve. But I say every one of us can do it if he wants. See that not only young people are in touch with the new technologies, but we have to go with this as well. So let me end with my lecture at this and say thank you very, very much to J.C. Kim, the inventor of the Artugate software, the genius behind it, and the one who is giving us all these opportunities. And of course, to Mr. Megagen himself, Dr. Park. I'm very, very proud to have met him last year. Before of Corona, I was able to go to Korea and see the incredible Mir hospital that he's having. Of course, not to forget the Art2Gate team with Dr. Sam Omar and Ingrida Piliaki. She is, and both of them are all the time helping me whenever they can. And last but not least, don't thank my team. I have to thank my team, Zahnärzte am Rathaus, who are making this possible, that I can do this. And of course, my best friend and dental technician master, Christian Rote, who is the one who constantly updates my way of thinking digitally and solving problems that come up with this new technology in my hand. Of course, I have to thank Christopher Jede from Zircons Customs, because he did this case for us. And the thing that I would like to remind you, like the Dalai Lama says, when you talk, you are only repeating what you already know. But if you listen, you may learn something new. So maybe I could have brought you some news today. So, at the end of my lecture, I'd like to thank you all. For any questions, please get in contact with me. I would love to have contact with all over, because I like to give my knowledge to someone who needs some help. And of course, the most important thing is stay healthy, and hope to see you again one day somewhere in this world. Thanks a lot, and bye.